Hi guys, so for today's video, we're going to talk about the examination of the nervous system. So for neurological examinations, there's actually 5 parts to this. So firstly, we need to assess the patient's mental status. So for mental status, we assess things like the patient's behavior, the patient's speech and language, like the appropriateness of their response to our questions, the level of alertness of the patient's orientation to like the date, the time, and the place, as well as the patient's mood and memory. The second part of the neurologic examination is the assessment of the cranial nerves. The third part is the assessment of the motor system, such as the patient's strength of the muscles, the coordination, and the patient's gait. The fourth one is the sensory system. And the fifth and the last one is the evaluation of the patient's reflexes. So for today's video, I want to focus mainly on the assessment of the cranial nerves, and I'll discuss the sensory, motor, and reflexes part in a separate video. So, so let's first talk about the cranial nerves themselves. So we have 12 cranial nerves, and the way I remember this is I use a mnemonic. I actually wrote it here. So I used the mnemonic, I don't know if you can see. So on occasion, our trusty truck acts funny. Very good vehicle anyhow. So I don't know if you could take like a screenshot of this. Sorry, I'm losing my voice today. Right guys, so I've come closer in case you can't read my writing. So I'm just gonna read out the words again. So on occasion, our trusty truck acts funny. Very good vehicle anyhow. So again, the first letter of each word corresponds to the first letter of the cranial nerve. So I'm just going to tell you the 12 cranial nerves now using, this mnemonic. So cranial nerve 1, we have the olfactory. Cranial nerve 2 is the optic. Cranial nerve 3 is the oculomotor. Cranial nerve 4 is the trochlear. Cranial nerve 5 is the trigeminal. Cranial nerve 6 is the abducens. Cranial nerve 7 is facial. Cranial nerve 8 is the vestibulocochlear. Cranial nerve 9 is the glossopharyngeal. Cranial nerve 10 is the vagus. Cranial nerve 11 is the spinal accessory nerve. Cranial nerve 12 is the hypoglossal. So this is a very useful mnemonic to remember all the names of the cranial nerves and their sequence. Also, I have a mnemonic to help me remember if the cranial nerve is a motor nerve or a sensory nerve or both. So I wrote it here as well. I'm not sure if you could see, but the mnemonic goes, some say marry money, but my brother says big brains matter more. Okay, so that's the writing in blue. I'm not sure if you could see. Again, I'll repeat. Some say marry money, but my brother says big brains matter more. So again, the first letter of each word corresponds, well, there's only 3, so it either starts with S, M, or B. So S means it's a sensory nerve, M means it's a motor nerve, B means both. So both sensory and motor. So as you can see here, the olfactory nerve is a sensory nerve. The optic nerve is a sensory nerve. The oculomotor nerve is a motor nerve, and so on and so forth. Okay, so these are the 2 mnemonics that I want you guys to learn to help you, name the cranial nerves and to help you identify whether they are sensory or motor or both. Starting with cranial nerve 1, or the olfactory nerve, which mediates our sense of smell, we first need to ensure that both nasal passages are patent. So the way that we check for this is we simply just compress one side of the nose or one nostril, and we ask the patient to sniff through the non-occluded side of the nose. And then we just repeat it onto the other side. And once we've established and we've ensured that both nasal passages are patent, we can then move on to the examination. So the examination involves like asking the patient to close their eyes so they can't see what we're doing. So once they've closed their eyes, we compress one nostril and we test the sense of smell in the non-occluded nostril by making them smell a familiar non-irritating odor such as coffee, vanilla, cinnamon, or soap. So We ask, if they can smell it, we ask them to identify what they're smelling. And then we just do that on the opposite side. So we occlude this side now and test the sense of smell in this non-occluded nasal passage with a different familiar non-irritating odor. Cranial nerve 2 is the optic nerve. So the optic nerve mediates our vision. So we need to test different elements of our vision. So we need to test for visual acuity using the Snellen chart. We need to test for visual fields using the finger wiggle test or the kinetic red target test. And then we need to examine the optic fundi using an ophthalmoscope. So we check for things like papilledema or the swelling of the optic nerves due to high intracranial pressure. We need to check for the pallor of the optic discs or like any cup enlargement, which may indicate glaucoma. So if you are not familiar with any of the tests I mentioned, so like the finger wiggle test, the kinetic red target test, or the Snellen test, please watch my HENT video. So I think it's on the part 1 of the examination where I talked about these specific tests. Cranial nerve 2 or the optic nerve can also be tested alongside cranial nerve 3 or the oculomotor nerve because they work so closely together. So a test for cranial nerve 2 and 3 is just examining the sizes of the pupils. So obviously look for symmetry. The medical term for an equal pupil size is anisocoria. So anisocoria is medically defined as the unequal pupil size, one being more than 0.4 millimeters bigger than the other. So this can be physiological. So I think it's actually seen in 38% of healthy individuals, but it can also be pathological. So this can be indicative of like cranial nerve 3 or the oculomotor nerve palsy. Also, for cranial nerve 2 and 3, we can test the pupillary reaction to light. So we look for the direct reflex and the concentric reflex. Again, if you don't know what I'm talking about, please watch the HENT videos. Also, we need to test the patient's near reaction. So that's pupillary constriction as the patient attempts to focus on a nearby object after looking at an object from a distance. Cranial nerve 3, 4, and 6. So those are the oculomotor, the trochlear, and the abducens. They control eye movements. So they work very closely together. So we can check them all together. So to do this, we need to check for the extraocular movements in the 6 cardinal directions of gaze. So again, I did this with the HENT examination, but I'll just do it really briefly. So we sit in front of the patient and we ask the patient to follow our fingers just with their eyes, without moving their heads. So we just make like an H shape. So I'll just show you. So please follow my finger just with the eyes, okay? So I just made like an H. And when we get to the middle, we check for convergence. So we do that by asking the patient to follow our finger as we move it closer to the bridge of their nose. Okay. So we look for any conjugate movements or the movement of both eyes to the same direction that causes diplopia in any of those 6 cardinal directions of gaze, if there's any. And if there's any, then we have to establish if the diplopia or double vision is monocular or binocular. And we do this simply by asking the patient to cover one eye and then the other. And then we also need to look out for or identify if there's any nystagmus. So nystagmus is just the rhythmic involuntary oscillations of the eye. They look like kind of jerking movements of the eye, which are involuntary. And if there's nystagmus, because in nystagmus there's like a slow component and a quick component. So firstly, we need to identify the direction of gaze from which nystagmus arises, or when nystagmus appears. And then we need to note down the direction of the quick component and the slow component. And just a quick side note, so the nystagmus is actually named for the direction of the quick component. So if the quick component's direction is to the right, then we say it's a right gaze nystagmus. And we also need to note the plane of the nystagmus. So is it vertical? Is it horizontal? Is it rotary, or is it mixed? And finally, for nystagmus, we need to ask the patient to fix their vision on a distant object, and we just examine or identify if the nystagmus increases or decreases as they fix their vision on an object that's far away. And then we also need to look for ptosis. So that's just the drooping of the eyelid. So this is commonly present in patients with a cranial nerve 3 palsy, or the palsy of the oculomotor nerve. It can also be seen in patients with myasthenia gravis. Moving on to cranial nerve 5, which is the trigeminal nerve. So according to this, the trigeminal nerve has both the motor and sensory components. So the motor portion of the trigeminal nerve innervates the muscles of mastication. So recall that that includes the temporal, the pterygoid, and the masseters. And the sensory portion of the trigeminal nerve mediates the facial sensation as well as the sensory part of the corneal reflex. So to examine the trigeminal nerve, firstly we have to examine the motor portion of this nerve. So we just ask the patient to clench their teeth, and we palpate the muscles of mastication. So the ones that are responsible for jaw clenching are the temporal and the masseters. So we palpate these muscles as we ask the patient to clench their teeth as hard as they can, and we note down the strength of the muscle contraction, and we identify if there's any unilateral weakness. Also, after this, we need to ask the patient to move their jaw side to side. And for this, it's actually the pterygoid muscles that are responsible for the lateral movement of the jaw. The sensory portion of the trigeminal nerve has actually got 3 divisions. So we have the ophthalmic, we have the mandibular, and the maxillary. So to test for the sensory portion of the trigeminal nerve, firstly, we need to explain to the patient what we're about to do, because we're going to test for pain. And we need to explain to the patient how we are going to assess for this pain or this pain response. So what we need to get is a suitable sharp object. So a good thing to use is like a wooden cotton swab stick. So we can break this cotton swab into half. And then imagine that there's going to be that sharp wooden end and this soft cotton end, okay? And we use the sharp end of that broken wooden stick as the sharp, the sharp end, and then the other end is the soft end. So we need to test for pain response in 3 different areas. So we need to test the forehead, the cheek, and the chin on both sides, okay? And we do this by asking the patient to close their eyes so they can't see which side we're putting onto their face. And then we ask them to, if they can feel the stimulus, we ask them to identify if they're feeling the soft or the sharp end, okay? So we just do that, and we ask them if they're feeling the sharp or the soft end. And if we suspect any abnormality, we can verify, we can confirm this by testing their temperature sensation. So we do the exact same test, but instead of a sharp and soft stimulus, what we use is a test tube filled with with hot, so one with hot water and one with cold water. And we just test the exact same positions, exact same areas of the face. As I mentioned earlier, the sensory part of the trigeminal nerve is also kind of responsible in mediating the sensory part of the corneal reflex. So therefore, we need to test for the corneal reflex. So to do this, first of all, we need to ask the patient to remove their contact lenses if they're wearing any, because this may diminish or even eliminate the corneal reflex. So once they've done that, we ask them to look up and away from the stimulus. And what we do is we approach from the side and we just touch their cornea with like a fine wisp of cotton. And we look for the normal reactions, such as blinking of the eye and tearing of the eye. So like the eyes becoming watery, which is the normal response to that stimulus. Cranial nerve 7, or the facial nerve, innervates all muscles involved in facial movement and expressions. And cranial nerve 7 also mediates the taste sensation. So to assess this, we inspect the patient's face at rest and when they're speaking during a conversation. And we note down any asymmetry or any tics or any abnormal facial movements. To test for cranial nerve 7, or the facial nerve, we ask the patient to do a couple of things. We ask them to raise their eyebrows. We ask them to frown. We ask them to puff out both of their cheeks. We ask them to smile. We ask them to close their eyes so tightly that you can't open them. And you test the strength of the muscular contraction by trying to open their eyelids. So I'll just demo. So I'm closing my eyes as tightly as I can, and the doctor attempts to open my eyelid to test the strength of muscular contraction. And then you can ask the patient to show both of their upper and lower teeth as well. So like this. Okay. So usually the patient should be able to do all of these movements with ease. So this should be very easy to the patients. And the movement should be symmetrical, like on both sides. And if there's any injury to cranial nerve 7, for example, in the case of Bell's palsy, then this can cause weakness in the facial muscles in one side of the face. Cranial nerve 8, or the vestibulocochlear nerve, which is also sometimes referred to as the acoustic nerve. But I don't like using the name acoustic nerve because yes, although this nerve is responsible or mediates hearing, it's also mediating like vestibular functions. And that just pertains to our sense of balance. So I feel like calling it the acoustic nerve doesn't do it much justice because there's more functions to that. So I feel like calling it vestibulocochlear just encompasses all of the other functions of this nerve. And I just feel like calling it the acoustic nerve is incomplete. So, but you may read acoustic in some literature and you may even hear it being referred to as the acoustic nerve. But anyway, cranial nerve 8, or the vestibulocochlear nerve, we test for the hearing part of this by doing the whispered voice test. So I think I spoke about this in the HE and the examination as well, but it's very simple, so I could just quickly just review the whole procedure. So what you do is basically you just say a combination of letters and numbers. Well, you whisper a combination of letters and numbers as you block or as you rub the contralateral ear, or the ear that you're not examining. So, and then you ask the patient to repeat the series of numbers and letters that you just whispered. So for instance, I'm gonna be the doctor and the patient. So, right, I'm rubbing or I'm blocking the contralateral ear, the ear that I'm not examining, and the doctor whispers 2, 5, J, okay? And I repeat 2, 5, J, okay? And if there is, so if you detect and then you repeat that on the other side, obviously. And if you detect that there is hearing loss, you need to establish if this hearing loss is sensory neural or a conductive hearing loss. And you do that by conducting or by doing the Rinne and the Weber test. I just want to quickly recap on the Rinne and the Weber test because these tests are very, very important. And it's very important for us to know how to interpret the results of the Rinne and the Weber test, which I didn't think I spoke about during that HE&T exam. So I want to do that today. Right, so, gosh, how am I going to start? Okay, right, so there are 2 ways. Okay, just bear with me. I'm just going to start from the very beginning. So there are 2 ways in which we hear, or in which we conduct the stimuli for the cranial nerve 8, or the vestibulocochlear nerve, to process it, okay? So these 2 ways are either via air conduction or via bone conduction. So the first way is air conduction. So that's when sound waves travel through the air and reaches our ear. It goes through our ear canal and ends up in the eardrum and then passes the information to our brain. Yeah. And the second way is through bone conduction. So that's when the sound waves travel through the bones of our skull, and it gets passed straight into the cochlea, or straight to the inner ear. And again, the information gets transmitted to our brain. And under normal circumstances, air conduction is greater than bone conduction, or air conduction is more efficient than bone conduction. Also, there are two types of hearing loss. So we have conductive hearing loss and we have sensory neural hearing loss. So in conductive hearing loss, usually this involves structures in the external and in the middle ear. So for instance, this can happen during otitis media, or if there is a blockage or an obstruction in the ear canal, or if there's a dysfunction in the tympanic membrane or the eardrum. So in conductive hearing loss, air conductance is impaired, okay? But bone conductance remains intact. Okay, bone conduction is unaffected. Okay, so actually, this may even result to the sound like seeming louder in the affected ear. Okay, compared to the unaffected ear, and there are a couple of hypotheses or theories behind this, and one of them that makes the most sense to me is that when air conduction is impaired, so for instance, air conduction is impaired in this ear, that causes the upregulation of the inner ear. So it makes the inner ear more sensitive to stimuli received via bone conduction, and therefore the sound that we hear in the affected ear actually appears louder or seems louder. Sensory neural hearing loss, on the other hand, happens because of a problem or an injury or something that goes wrong in the inner ear or the cochlea or the vestibulocochlear nerve itself. Okay, so in sensory neural hearing loss, there is impairment in both of the air conduction and the bone conduction. So this means that the affected ear, the sounds will appear quieter compared to the unaffected ear. To help us identify whether the hearing loss is because of a conductive hearing loss or due to a sensory neural hearing loss, we can use both the Weber test and the Rene test combined, okay? We can't just use one because that's not going to give us a lot of information. So we have to use them in conjunction with each other. So let's first start discussing the Weber test. So with the Weber test, what you have to do is you have to strike a 512 hertz tuning fork, put it on top of the patient's head, kind of like in the middle, and ask the patient where they hear the sound, okay, or where they hear the sound the loudest. So what I'm doing here is I'm trying to have the sound waves transmit via bone conduction. And physiologically speaking, what needs to happen is that obviously there should be equal transmission on both sides, right? So that's a normal finding, but you have to be careful because the patient would report the same finding if they have bilateral sensory neural hearing loss and bilateral conductive hearing loss, okay? So if the Weber test, if the patient says that I hear it on both sides of my ear, that could have three possible outcomes. That could be either normal, either bilateral sensory neural hearing loss, or bilateral conductive hearing loss. That's why you need to do other tests to determine which one it is, okay? So if the patient, so if you strike the tuning fork, put it on top of the patient's head, and they report unilateral, if they report that it's like louder in one side, so for instance, it's louder on my right side, we call that lateralization. So if it's louder on the right side, I'd say that the Weber test is lateralized on the right side, yeah? So that just means that it's louder on the right side. So if it's louder on the right side, what can that mean? So that can mean two things. So that can mean that I have conductive hearing loss in this ear, because in conductive hearing loss, the sound will lateralize to the affected side. Or I can have sensory neural hearing loss on the other ear, because in unilateral sensory hearing loss, the sound will lateralize towards the unaffected side, okay? So just to summarize that, because I know it can be confusing. So I strike a tuning fork, put it on top of the patient's head. if the patient reports that I hear them equally on both sides, that could be normal, that could be bilateral sensory neural hearing loss, that could be bilateral conductive hearing loss. If the patient reports lateralization to one side, for instance, the right side, that can mean that I have, or the patient has, conductive hearing loss on the right side, because in unilateral conductive hearing loss, the sound will lateralize towards the affected side, or the patient can have sensory neural hearing loss on the opposite ear, because in unilateral sensory neural hearing loss, the sound will lateralize towards the unaffected side. Okay, so I hope that's clear. For the Rinne test, this allows for the unilateral comparison of air conduction to bone conduction. So I'm just gonna say this again because this is a very important concept. So physiologically speaking, right, air conduction is more efficient or is greater than bone conduction, right? That's in normal circumstances. That's what we would expect, yeah? Air conduction is greater than bone conduction. So for the Rinne test, what we do is we strike a tuning fork, yeah? We put it on the mastoid bone, so it's just behind the ear. And then when the patient, so what's happening now is there's gonna be sound conduction through the bones. So this is gonna be sound waves transmitted, to the inner ear via bone conduction, right? And then what I do is ask the patient to tell me when they can't hear the sound anymore. So when they can't hear the sound anymore, I place it next to their ear, right? And if they can't hear this anymore, then this is a negative Rinne test. So negative Rinne test indicates an impaired air conduction, right? So this means that this ear has conductive hearing loss, right? So the other result could be, so I strike the tuning fork, I place it on the mastoid process, and I allow for bone conduction, so they hear the sound, and then I ask them when they can't hear the sound anymore. I place it next to their ear, and if they can still hear the sound, this can have, this can indicate two things. So one can be, it's either like a normal ear because air conduction is functioning, or this ear has sensory neural hearing loss. Just to repeat that in more common language. Okay, so I'm really trying hard to explain this, right? So I strike that 512 hertz tuning fork, right? I put it on the mastoid bone. So now what's happening is there's bone conduction. So I ask the patient to tell me when they can't hear the sound anymore. If they can't hear anymore, I place it next to their ear. If they can't hear the sound at this stage anymore, this is a negative Rinne test. And a negative Rinne test indicates a conductive hearing loss in this ear because this indicates an impaired air conduction, right? And if I strike the tuning fork, put it on the mastoid bone, and then when they can't hear anymore, place it next to their ear. If they can still hear that sound, this is a positive Rinne test. And this can indicate one of two things. It can indicate that this ear is either normal or this ear has sensory neural hearing loss. Just bear with me while I talk about the Rinne and the Weber test a bit more in detail because I really want you to understand this because this is really, really important. So now let's talk about interpreting the results of the Rinne test and the Weber test, yeah? So a patient comes to your clinic and you do the whispered voice test and you suspect hearing loss. So you do the Rinne test and the Weber test. So the Rinne test shows bilaterally positive on both sides, and the Weber test shows lateralization to the right side, right? So let's interpret these results together. Let's first start with the Weber test. So the Weber test shows lateralization to the right side. So this means that when I do this, the patient hears it louder on the right side. Now, what can this indicate? So this can indicate two things, yeah? So this can indicate unilateral conductive hearing loss on the right side or unilateral sensory neural hearing loss on the left side, yeah? And then the Rene test showed us bilateral positive. So positive in both sides, which means that air conduction is working on both sides, right? So this does not support the conclusion that there is conductive hearing loss on this right side because air conductance is working based on the Rene test. So what does this person have? So this person has a left ear sensory neural hearing loss. Okay, so I hope that makes sense. And I'll give you another example. So let's use this patient. So this patient comes into your clinic. Again, you suspect hearing loss. So you do the Weber and the Rene test. And when you do the Weber test, it shows no lateralization. And the Rene test is positive bilaterally. Okay, so let's interpret these results together again. So starting with the Weber test, it says no lateralization. So what's that mean? So it means that when I do this, the patient hears the sound equally on both sides, right? So what can that indicate? That can indicate one of three things. It can be normal hearing on both sides. The patient can have bilateral conductive hearing loss or bilateral sensory neural hearing loss, yeah? So we need to distinguish between these three potential diagnoses. So the Rene test tells us that it's positive bilaterally, right? So positive bilaterally means that air conductance is working, right? In both sides. So this does not support the conclusion that the patient has bilateral conductive hearing loss because air conduction is working. So what does this patient have then? So this patient can either be normal, can have normal hearing on both sides, or the patient can have bilateral sensory neural hearing loss. So I hope that makes sense. I don't know, just ask me if you want more examples, if it still does not make sense, but I hope it does. So now we can go back to talking about the examination of the remaining cranial nerves. Moving on to cranial nerves 9 and 10. So let's just remind ourselves what those are. So 9 is the glossopharyngeal and 10 is the vagus. So the vagus nerve and the glossopharyngeal nerve, they mediate the sensory and the motor functions of the soft palate, the pharynx, and the larynx. Right. So to check for the functions of these nerves, we can ask the patient to say ah or to yawn, yeah? And we check for the movement of the soft palate. So the soft palate has to rise symmetrically, and therefore the uvula will be pulled with the soft palate and will remain in the midline. And the posterior pharynx should move medially, okay? So if there is bilateral lesion in the vagus nerve, in the cranial nerve 10, then the soft palate will fail to rise, yeah? It will just not move up at all. If there is unilateral lesion in the vagus nerve, what will happen is that the soft palate on the side of the lesion will fail to rise. And on the normal side, it will rise and it will pull the uvula with it. So just to illustrate this, so for example, I have a lesion in the vagus nerve affecting the left side, yeah? And the right side is normal. So what's gonna happen is my soft palate on this side will not rise, and the soft palate on this side will rise, and it will kind of pull the uvula with it. So you know the uvula is in the middle. It should be in the middle. But because this has a lesion, this is normal, it gets pulled towards this side, right? So to identify which side has the lesion, the uvula will point away from the side of the lesion. So the uvula is pointing to the normal side, away from the side of the lesion. So that's how you tell. Okay, we also can test for the gag reflex. So for the gag reflex, what we do is we just need to lightly stimulate the back of the throat, one side at a time, okay? And if there is unilateral absence of gag reflex, then we need to suspect lesions in either cranial nerve 9 or cranial nerve 10. Cranial nerve 11, or the spinal accessory nerve, innervates the trapezii, so both the trapezius, and the sternocleidomastoid muscles, right? So to test this, the doctor should go behind the patient and place like both hands on the trapezii. And the doctor needs to ask the patient to shrug straight up against the doctor's hand that's putting like a downward pressure, right? So imagine the doctor's hands are on my traps, and I just shrug straight up. Yeah, you could actually see my traps are quite big. So what the doctor needs to evaluate is the strength of the contraction of the trapezii, right? Noting any weakness, okay? And then to test the strength of the sternocleidomastoid, what the doctor needs to do is from the front, so the doctor is in front of me, place one hand against the patient's cheek and chin, and ask the patient to turn his or her head against that hand that's pushing to that side, so pushing medially, right? So I do this. So I'm pushing with my hand, and I'm trying to turn my head against that hand. So the doctor needs to observe for the contraction on the opposite sternocleidomastoid muscle, again noting for the strength of the contraction based on the force that he can feel on the hand. And finally, we have cranial nerve 12, or the hypoglossal nerve. So if you made it this far, congratulations. I know it's really, really long, and there are so many nerves that we need to test for. But so cranial nerve 12 is the hypoglossal nerve. So it has motor functions. So this actually mediates the motor functions of our tongue, which affects the articulation of the words. So to examine this nerve, the function of this nerve, we can observe the patient's articulation of words, and we note if there's any poor articulation of the patient's words, which is medically known as dysarthria. Okay, so that just means poor articulation of words. And then we can inspect the tongue when it's when it's inside the mouth of the patient. We look for things like atrophy or any fasciculations. And then we ask the patient to stick their tongue out, and we look for things like the symmetry, atrophy of the tongue, and any asymmetric protrusion. So if the tongue is asymmetrically protruded, so it means it protrudes to one side, then that suggests a lesion in the hypoglossal nerve, and the tongue will point towards the side of the lesion. Okay, so that's very important to remember. The tongue will point towards the side of the lesion if there's a lesion in the hypoglossal nerve. And finally, while the patient has their tongue out, we can ask the patient to move their tongue side to side just to assess for the symmetry of the movement.